Good afternoon, everyone. I'm Ramesh Sachdeva. Welcome to the VPS Research Spotlight session. Sorry for the minute or two of delay, trying to get the video to get working. We have a really exciting topic this afternoon, looking at the use and duration of pre-intubation respiratory support and its relationship to mortality in immunocompromised children with acute respiratory failure. I think this is really relevant. This is something which all of us in the intensive care unit, we are increasingly using modalities like high flow and NIPPV. And we typically think of this as the step prior to intubation. But the study really highlights an important point that what about certain select groups? Is this a good idea? Or should we be considering intubation sooner? Really important clinical question, which could change our practice. So it's a real pleasure to welcome our speaker and the author of this study, Dr. Lindell. Dr. Lindell, Dr. Lindell is currently a faculty at the University of Pennsylvania, Children's Hospital of Philadelphia, and did his training in pediatrics, including a year as chief resident in peds, and then a fellowship in critical care medicine from CHOP. Prior to that, he completed his medical training from Vanderbilt University School of Medicine. Dr. Lindell has an impressive career and a really growing list of publications and research activities. I think one of the very important ones is a recent K-12 award, which is really focusing with Dr. Lindell as the principal investigator and focusing on linking immunotypes and outcomes in pediatric sepsis. So the work he'll be sharing this afternoon, I think really dovetails with some of the other research work that Dr. Lindell has been involved in. So without any delay, request Brad to please get started.
I want to just say thank you for the generous introduction and for the opportunity to speak to the group today. We're going to be discussing, as you mentioned, our article, which really focused on how we care for children with respiratory failure in the PICU, and then how our medical decision-making may have an impact on their clinical trajectory. And while I'm giving today's talk, I want to start by acknowledging the team, which was really behind the development and creation of this study and the research networks that we represent. We were a diverse team of clinician scientists from varied institutions and career stages, and I was honored to be able to be part of the team and then to present this to you today. I've been on lots of clinical and research teams, and this one was absolutely top-notch and just a great group of people to get to learn from the process. When we started planning this project in 2020, our study questions were informed by several recent observational studies, which really focused on the clinical management of children with respiratory failure. First, we knew that children who were exposed to high flow or non-invasive ventilation prior to invasive ventilation tended to have longer courses of mechanical ventilation. Second, we knew that immunocompromised status was associated with both respiratory failure and PICU mortality in sepsis patients. Third, we knew from search that increased PICU length of stay prior to intubation was associated with mortality in stem cell transplant patients. And finally, we knew that in a well-designed randomized study of early versus late non-invasive in immunocompromised children, there was a trend towards increased mortality associated with the use of non-invasive. And those studies really defined what we considered to be the knowledge gap, that there was an absence of clinical trial data or consistent observational data to guide the use of high flow or non-invasive in immunocompromised and stem cell transplant patients with acute respiratory failure. Given that knowledge gap, we created our study with the objectives of determining the association between pre-intubation respiratory support and outcomes in patients with respiratory failure, and then as well to determine the impact of these immunocompromised diagnoses on outcomes after adjustment for illness severity. We chose to pursue this question through the multi-center VPS data set, as data regarding respiratory support modalities and immunocompromised status are both well characterized in VPS. And as a group, we created three a priori hypotheses. First, that pre-intubation respiratory support would be associated with increased PICU mortality in immunocompromised and stem cell transplant patients in a time-dependent manner. Second, that mortality would vary by immunocompromised status. And third, that patient outcomes would also vary by center. We collected retrospective patient data from a 6-year period, excluding patients with chronic invasive or non-invasive ventilation. We started with a population of almost 25,000 patients, excluded patients from sites that did not consistently report high flow and non-invasive data at the time of admission, excluded patients who were intubated outside of the ICU but are still captured in VPS, as well as a group of patients who were intubated for less than 24 hours, with the rationale that those could represent procedural intubations. We excluded a group of patients for whom there was incomplete data regarding the timing of either high-flow nasal cannula, non-invasive, or intubation, and only considered cases where we had complete data on all interventions. And then finally, we excluded a very small number of patients from 35 sites who reported fewer than 10 total intubations during the study period. Most of these were centers who were briefly contributing data to VPS during the particular study period that we looked at. And that left us just over 5,000 patients who were intubated across 82 sites. Our primary outcome for the study was all-cause PICU mortality, which is coded in VPS and pretty straightforward. Our exposure of interest was the use of high-flow nasal cannula or non-invasive prior to intratracheal intubation. This was defined by VPS procedure codes, which are required fields across all the sites. The timing and duration were reported by the majority of sites, and obviously for all of the patients included in the study. And then importantly, for patients who had sequential exposures to both modes of support, we selected the final mode of support prior to intubation as the exposure for the study. We also created an additional immunocompromised exposure variable. This was defined by our previously validated ICD-9 codes and was a trichotomous variable where patients were classified either as having no immunocompromised diagnosis, immunocompromised without exposure to stem cell transplant, and hematopoietic cell transplant. Initially, we sought to test the hypothesis that pre-intubation respiratory support is associated with increased PICU mortality in stem cell transplant and immunocompromised patients in a time-dependent manner. This is table 1, which shows the distributions of our covariates across the 3 immune statuses. As expected, our a priori covariates of age and severity of illness varied by group, and we also included sex as a biologic variable in our analysis. We also noted in this first pass that rates of severe sepsis and septic shock varied by immunocompromised status and included sepsis in a subsequent sensitivity analysis, which we'll discuss. In our primary analysis, we constructed a mixed effects model incorporating our a priori defined patient level and center level fixed effects. In both immunocompromised and in stem cell transplant patients, exposure to high-flow nasal cannula or non-invasive ventilation was associated with an increased odds of mortality compared to patients who were intubated without any pre-intubation respiratory support. We then conducted a post-hoc sensitivity analysis incorporating sepsis, as I mentioned before, which did not change this association between pre-intubation support and PICU mortality. So having identified this association between pre-intubation respiratory support factors and mortality in immunocompromised and stem cell transplant patients, we then sought to test the hypothesis that this risk of mortality would vary based on duration of exposure. We first, this was a little complicated to decide how to do, and we first tested this hypothesis by stratifying patients based on the duration of their exposure to both therapies into quintiles. So this is figure 1 from the patient, and we can see visually in panel A, we see patients exposed to high-flow nasal cannula prior to intubation, and in panel B, patients exposed to non-invasive ventilation. And we can see visually that immunocompromised and stem cell transplant patients have a higher PICU mortality rate than patients without an immunocompromised diagnosis, both overall and within their matched quintiles. Additionally, there appears to be an ordinal trend of increased mortality by duration of exposure to pre-intubation support. And we see that, in fact, this trend reaches our pre-specified alpha among stem cell transplant patients, but not any of the other groups. Based on this finding, we decided to add an unplanned secondary analysis to dichotomize patients based on a 6-hour duration of exposure to high flow or non-invasive ventilation prior to intubation. Our rationale for this post hoc analysis was that 6 hours represents a clinically meaningful trial of respiratory support, and that a 6-hour observation window was used to assess response to PEDS ARDS therapies in the PARTY study. And in that analysis, stem cell transplant patients had an increased odds, had an increased odds of mortality associated with greater than 6-hour duration of pre-intubation exposure to high flow nasal cannula or non-invasive compared to stem cell transplant patients who were exposed for less than 6 hours. This finding that the duration of exposure to high flow or non-invasive ventilation is associated with mortality in stem cell transplant patients is consistent with Courtney's findings from the SEARCH database several years back. And to our surprise, longer duration of high flow and non-invasive exposure was not associated with increased mortality in immunocompromised patients without stem cell transplant or in patients without an immunocompromised diagnosis. Finally, we hypothesized that patient outcomes would vary by center. First, let me orient you to the caterpillar plots that we use to examine these results. In each graph, individual centers are displayed on the horizontal axis, and the adjusted mortality rate by center is shown. The size of the point estimate corresponds to the volume within each center, and error bars represent 95% confidence intervals. Adjusted mortality rate for the entire cohort is indicated by the broken line and is just above 20% in the base model. For this analysis, we use median odds ratio to quantify the center level variance in PICU mortality. And briefly, median odds ratio is a function of cluster variance and quantifies the heterogeneity of outcomes between centers. Mathematically, it represents the median increased odds of mortality that would be associated with moving a patient from a lower risk center to a higher risk center. When we add our patient level fixed effects to the mixed effects model, we see that the median odds ratio is essentially unchanged. We interpret this to mean that patient level factors, at least the measured ones, have little impact on the degree of center level variance in patient outcomes. And finally, when we add our center level fixed effects to the mixed effects model, we see that the median odds ratio remains similar. I've shown just the non-invasive model here, but the results of the high flow nasal cannula model in the paper are similar. And these findings are congruent with prior reports that center level variability in the use and duration of high flow nasal cannula and non-invasive use in pediatric respiratory failure is wide. I believe our results suggest that this variability in care practice may in fact be associated with differences in ICU mortality. So to briefly summarize the findings from the paper, first, we found that immunocompromised diagnoses are common in children with respiratory failure. In this analysis, it represented almost half of the cohort and 60% of the mortalities. Stem cell transplant is a major risk factor for PICU mortality among children who have respiratory failure, which has been shown by others and re-demonstrated in this analysis. Third, and importantly, in the absence of immunocompromised or stem cell transplant conditions, exposure to pre-intubation respiratory support is not associated with PICU mortality, suggesting that there's a heterogeneity of treatment effect based on immunocompromised status. Fourth, that longer duration of pre-intubation respiratory support is associated with mortality in stem cell transplant patients, which has led some, including the editorial that came out alongside this article, to suggest that a time-limited trial to assess physiologic response is the best way to use non-invasive in these patients. And finally, as expected, PICU mortality does vary significantly by center. Now, my personal interest in this project, other than working with all these great people and answering our questions, was to show that immunocompromised children fundamentally respond differently to our therapies. And I believe that's what we found. This heterogeneity of treatment effect is essential to understand both as a clinician and also as a clinical and translational researcher. This is a classic diagram used to discuss prognostic and predictive enrichment with the goal of leveraging this heterogeneity to identify precision therapies for patient subgroups. In both sepsis and respiratory failure, immunocompromised status is a prognostic enrichment strategy with increased mortality and a differential response to therapies. My work is now focused on using this on defining the underlying biology which drives this differential response to therapies within immunocompromised patients. Paradigm Shift is a single center prospective cohort study which uses a suite of 4 immune profiling assays to test the hypothesis that reversible immune mechanisms exist and are associated with clinical outcomes in these patients. In our first 100 patients in that study, we've shown that MOD severity and duration are predicted by specific cellular immune phenotypes. And our ongoing work in this project uses plasma proteins and single cell transcriptomics to identify the fundamental mechanisms which underlie this immunopathology. I can't say that we have any data that's ready for prime time yet, but hopefully we'll have a preprint ready by the fall. And I share all this data because I'm excited about it and have spent a tremendous amount of time working on it, but also because I want to acknowledge the essential role that VPS data played in my own career development and the development of this science. As a fellow and then junior faculty member, VPS data allowed me to construct observational studies which highlighted the impact of immunocompromised status on clinical outcomes in PICU patients, and most recently in this paper, the potential differential effect that our therapies may have on these patients. The findings from these studies directly informed the subsequent translational questions that I was able to ask, and ultimately led to the development of paradigm shift and our subsequent immune profiling work. I want to wrap up because we should leave time for questions, but I owe a tremendous debt of gratitude to all the people who invited me today, as well as the families and patients who contributed samples and data to the work, to my mentors and sponsors and collaborators who have supported me over the 11 years that I've stuck around here at CHOP, the Triple CEO group here at CHOP, who abstracts all of our local VPS data and taught me the strengths and limitations and how to work with the data when I was a fellow, my clinical and translational research teams who really are instrumental in making all parts of Paradigm Shift a success, and to all the funders who believed in this work. I want to thank all of you for joining today to talk about the paper, and I'd be happy to take questions at this time. Thank you.
Thank you, Dr. Lindell, for an excellent summary, and congratulations on an outstanding research trajectory and journey in this important area.
Thank you.
I think you're open for questions. As you're waiting for questions, I do have actually one or two questions came up in my own mind. One is, as a clinician, it's fascinating to see the connection from the observational study to the bench, and then bringing it back to the bedside. Has this changed your clinical practice when you're on call at night? Like, do you do things differently as a result of this?
Yeah, I wish I could say that I did. I think, if anything, this work has made me more aware of how difficult risk stratification really is, and how the preconceived biases that we bring to the work about how a patient may do are informed much more by our priors and not necessarily by the biology of the patients. So I have to say, I found it incredibly difficult to decide exactly how to contextualize things. Now, do I think about it every single day? I do, and hopefully it makes me a better clinician, but I do think it's really hard to decide what to do. Yeah. I think the other thing to say is, so after this paper came out, most of the discussions revolved around what to do with these time-limited trials, and did we really have data to say what should happen? And I stand by the data. I think it says what it says, but it's clearly a small subset observational study that suggests potentially confounded association with mortality. We worked really hard to try to prove that it was not that association was in fact not due to measured confounders, and I think because it aligns with other research from other people, I feel pretty strongly about that. But the question of how you apply this population-based research to an individual patient still eludes me. If anyone has advice, please let me know. Of
course, I'm sure it'll come in the days ahead. Dr. Lindell, there are actually a couple of questions from the audience. The first is from Jamie. Jamie compliments you on an excellent paper and a presentation. And her question is, how did you identify the patients who were chronically ventilated?
Yes, so patients with tracheostomy were excluded regardless of if they were ventilated or not, because they couldn't be intubated. So all of our patients were natural airway when they came in. And then for patients with chronic exposure to non-invasive ventilation, we used a variety of methods, and this was one of the more challenging parts to feel like we got right. We looked for diagnosis codes associated with chronic respiratory failure and ventilation, and then we looked at the start time of non-invasive use, which is reported across all centers. And for patients who were on non-invasive prior to their ED start time, we assumed that those patients had chronic non-invasive support.
Great, thank you. We have another question from Jenny. Dr. MacArthur asks that, why do you think that patients with hematopoietic cell transplants are more susceptible to worse outcomes when exposed to pre-intubation non-invasive ventilation?
Yeah. Hi, Jenny. Thank you for your question. I think that's a great, it's one of the great mysteries of this. It would seem like supporting those patients with non-invasive would be a successful strategy. I think that's why many people do it. Things that we've discussed as a group as we were preparing this report was that a period of time where patients are under-supported with progressive lung injury could be associated with their worse outcomes. Tying that to mortality is more complicated perhaps than longer linked or severity of illness, which we weren't able to do in this analysis. I know that Courtney's data has suggested that increased exposure to supplemental oxygen in and of itself is a risk factor for ICU mortality in these patients. And so it either reflects a prognostic enrichment strategy that doesn't have a biologic basis, or I think the most generous interpretation would be that patients are better supported. Patients fail to develop as severe lung injury if they're well supported early on with invasive ventilation. Though I certainly don't have data to say that that's true.
Great, thank you. We have a question from Gerardo. This is an analytical statistical question. Gerardo asks, did you try a different model, which includes the base model plus the center factors only approach? And if we didn't attempt that, what do you think could have emerged from such an analysis?
Sure. So hi, Gerardo. It's nice to see you again. Gerardo helped me early on with my sepsis work, and I bugged him for years. So it's nice to talk to you again. We did not specifically analyze that. What we found, our center level factors were a random effect associated with each center, and then a fixed effect associated with the volume of intubations that center performs. And that was based on some suggestion in Near for Kids data that higher volume intubation centers might have different care practices. I would say that what we found is that center level factor had very little impact on the patient outcomes, as perhaps we would all expect.
Great, thank you. We have another question just come up from Scott. Scott compliments you on an excellent talk. And it's an interesting point that Scott raises, that we can think of NIV as potentially harmful to causing lung injury. But another way of thinking is that these patients may have a different underlying pathology who need sort of early intubation. And the question specifically is that, did you all look at the various causes of respiratory failure in your study, which may in turn shed light on a different pathological sort of a process that's going on?
So we did not. I think it's a really great point, and certainly the observational data that we have limits what we're able to analyze, causes sort of teasing out ARDS in general in observational data and in VPS specifically has been a little bit elusive. And Garrett Keim here has worked on that a lot, and he and I have collaborated some because Scott helped me derive our sepsis codes, which worked very nicely. But ARDS is even more nebulous, it seems, than sepsis, and lacks a specific diagnosis code. So we did not include that analysis because we didn't feel like we had a validated way of adjudicating that. In Paradigm Shift, we are collecting all that information, although we don't have, it's 3 years and 100 patients in a single center. So we'll never have the breadth that a VPS study could have. But I think it's a well-taken point.
Great. Brad, I know we have just a few moments left. One question that just occurred to me, I think we don't have any more questions from our audience.
Okay.
But could you speculate at all, based upon the subgroup that's kind of behaves a little differently, based upon your clinical experience and your research work in this area, could there be other subgroups like immunocompromised patients who may also not benefit with non-invasive ventilation and may need early intubation? Because that could impact, could there be other groups too? Any thoughts on that particular idea?
So ready for prime time? No, I have no thoughts at all. But I have to say, so our protein data that we're looking at now really looks at immune mediators and markers of endothelial dysfunction, and then cellular metabolic function. And the heterogeneity within the cohort is remarkable. And when you narrow in on patients with respiratory failure, it's very clear that that there's different flavors of what that respiratory failure looks like, at least in the protein data. The degree of respiratory failure and cardiac failure seem to be the two most highly driven by protein profile, whereas other organ failures seem to be more driven by time and by cellular immune profiles. So I think there certainly is something there. The interplay of what the circulating proteome looks like and what's happening in the lung and what our therapies do to that is that would be an amazing study.
Thank you. I know we are right at 4:30 Eastern time, our allocated time for this discussion this afternoon. Dr. Lindell, just want to thank you for an excellent presentation, sharing your remarkable work with the group, and good luck with your future research. We look forward to continue to hear your findings in the days ahead. I also want to remind the audience that the next VPS Research Spotlight session is on August 16th. So please mark that date, August 16th. And thank you all for joining this afternoon, and have a wonderful rest of the day. Thank you.
Thank you.